Hey everyone, it's Sarah, registered nurse, RN.com, and in this video we're going to be continuing our series on shock. Today we're going to be talking about cardiogenic shock. Now after you watch this YouTube video, you can access the free quiz that will test you on this condition. So let's get started. First, let's start out talking about what is cardiogenic shock. It occurs when the heart cannot pump enough blood to meet the perfusion needs of the body. So this condition is solely an issue with this heart itself, hence why we call it cardiogenic shock. Now, why does it occur? Well, it can occur for multiple reasons. Number one, it can occur due to a filling issue. There's an issue with these chambers of the heart being able to fill properly, and this is known as diastolic dysfunction. Or there can be an issue with contraction of the heart. So the heart is having a problem actually getting that blood and moving it forward out of the heart, and that is known as a systolic dysfunction. Or you can have some type of dysrhythmia presenting or some type of structural defect. And a little bit later, we will go into some conditions that can cause diastolic or systolic dysfunction, but just keep that in mind. Now, one thing with cardiogenic shock I want you to remember is that it doesn't present due to a loss of blood volume for the heart to pump. The heart has plenty of blood volume to pump. It just really can't pump it out of the heart and maintain cardiac output. So that leads to a decrease in cardiac output. Now I really want you to remember cardiac output because this is a big term we're going to talk about throughout this lecture. Now what is it? Well, it's the amount of blood that the heart pumps per minute, and it's determined by a couple factors: the heart rate and the stroke volume. And stroke volume can be determined by your preload, afterload, and contractility. And whenever we're talking about treatment, we can give medications that can help manipulate that stroke volume, hence increasing our cardiac output. So whenever we have a decrease in cardiac output, we're going to have decreased perfusion because this heart can't get its blood volume out to go to supply the organs, the tissues. So those cells that make up the organs and tissues aren't being perfused. So if they're not receiving fresh oxygenated blood, what's going to happen? They're going to receive a decreased amount of oxygen, and that can lead to cell hypoxic injury, and we talked in depth about that in our previous video about the stages of shock. Now, to help us truly understand cardiogenic shock, we have to go back to the basics and we have to talk about the role of the heart. Our heart is the pump of the body, and there is no other organ in our body that can do what the heart does. And what's interesting is that every organ in the body depends on the heart. So if the heart can't pump correctly, everything else suffers because the heart supplies your organs and your tissue cells with fresh oxygen, and they need oxygen to work. And if the cardiac output falls, which is the amount of blood that heart pumps per minute, that means that those cells aren't receiving adequate amounts of oxygen. So as we learned in the stages of shock, once that cardiac output starts to fall, the patient will enter into those stages. And in the end, if it's not corrected, the cells that make up the organs completely shut down and die, and death occurs. So what your heart does is that it receives blood to its right side. Everything starts in the right side, and the whole goal is to take blood, recycle it, put fresh oxygen in it, and pump it back out to the body. So we have oxygen, we have blood that's depleted of oxygen, comes in through the superior inferior vena cava, down through the right atrium, then through the tricuspid valve, the right ventricle, which shoots it up through the pulmonic valve, and then into the pulmonary artery, which goes into the lungs. And in the lungs, gas exchange occurs. And you have the crossover of carbon dioxide that has built up in the blood. The person will exhale that out. Then the oxygen that person has taken in will cross over and go into the blood. And then it will go back to the left side of the heart through the pulmonary vein. And the goal of the left side is to take that oxygenated blood and pump it throughout the body. So it'll go through the pulmonary vein, through the left atrium, down through the bicuspid/mitral valve, then through the left ventricle. And the left ventricle is the main pumping chamber of the heart. It's extremely strong, and it's a very important chamber because if it fails to work and contract, we have major problems. And when we talk about the causes in an acute myocardial infarction, if you get damage to this left ventricle, its muscle, we can have cardiogenic shock. So left ventricle pumps it up through the aortic valve, then through the aorta, and the aorta will supply the body. It'll branch off into this complex network of arteries and will go to every single organ, tissue, and supply the body with fresh oxygenated blood. Now let's talk about this thing called cardiac output. Understanding cardiac output is really the backbone of understanding cardiogenic shock. So let's go over it. Okay. As I have pointed out, cardiac output is what? It's the amount of blood pumped by this heart per minute. So how much blood should your heart be pumping per minute? It should be pumping anywhere between 4 to 8 liters per minute. Now, how can we determine cardiac output? Well, you can take the heart rate and multiply it by stroke volume. Now let's talk about stroke volume for a moment. If we can increase stroke volume in the management of cardiogenic shock, we can increase cardiac output. We increase cardiac output, which is the amount of blood that this heart is pumping per minute. We can increase perfusion to those cells that make up the tissues and organs. They receive more oxygen, they're happy, and they don't start to die. So stroke volume is the amount of blood pumped by the left ventricle with each beat, which should be anywhere between 50 to 100 mLs. Now, stroke volume is determined by 3 factors, and these 3 factors can be manipulated with medications to increase stroke volume. So let's talk about those 3 factors. They include preload, afterload, and contractility. So preload is the amount those ventricles stretch at the end of diastole. Diastole is where the heart is relaxing and it's filling with blood. So at the end, when it's done filling, at the end of that part of diastole, it's the amount that those ventricles have stretched once it's filled. Afterload is the pressure the ventricle must pump against, squeeze against, to get blood out of the heart. And then contractility is how well those muscle cells that make up that heart that help it contract, how well they're contracting. So it's the strength of the heart with each contraction. Now let's talk about some examples. Okay, if we give a patient a drug that increases contractility, like a positive inotropic drug like dobutamine, dopamine, if we increase contractility, we're increasing how well those muscle cells are contracting. What's that going to do to stroke volume? It's going to increase stroke volume. Okay, afterload. Let's say we decrease that resistance that heart has to pump against. It's going to make it easier for the heart to pump. So if we decrease afterload, we're going to increase our stroke volume. We can do that with like vasodilators. Now, with preload, let's say we give them a vasopressor. It's pressing down our vascular system. It's causing vasoconstriction. When you vasoconstrict, you're compressing everything. You're going to increase venous return to the body. So you're increasing the amount of blood that's coming to this heart, which is going to increase how much is filling in that ventricle, how much it's going to have to stretch. You're increasing its preload. You bet you're going to increase its stroke volume as well. So we can increase preload, increase contractility, decrease our afterload. We're going to increase our stroke volume, which is going to increase our cardiac output. Now, another term you may see whenever talking about cardiogenic shock is something called cardiac index. And all this is it's a more specific measurement of cardiac output based on the patient's body size. So it's calculated by taking the cardiac output and dividing it by the patient's body surface area. And for patients who are in cardiogenic shock, their cardiac index will be less than 2.2 liters per minute per meter squared. And you want a normal cardiac index to be anywhere between 2.5 to 4 liters per minute per meter squared. Now let's talk about the causes of cardiogenic shock. Okay, what are some conditions that can occur in the body that will make this heart's cardiac output fall so low that it can no longer meet the perfusion needs of our cells, tissues, and organs, so they receive decreased oxygen? Well, one of the main causes of this condition is if a patient experiences an acute myocardial infarction, which is also called a heart attack. And what happens during a heart attack is that the coronary arteries that set on your heart muscle have become blocked. They can become blocked with a fatty plaque, a clot, or something. But whatever the cause, it's decreased blood flow to that heart muscle. And wherever it's decreasing blood flow to that heart muscle, those cells that make up the heart are going to not work. And after so long, those cells can just die, and it's irreversible. So that can lead to your heart not pumping efficiently, hence stroke volume is majorly going to be affected, which is going to make cardiac output fall. And this is one of those systolic dysfunctions. So there's going to be an issue with this heart being able to move blood forward and out of the heart. And one type of acute MI that can cause this is if the coronary artery that feeds the left ventricle becomes blocked. Because remember, what did I say about the left ventricle? It's the main pumping chamber of the heart. So the coronary artery that sets on that left ventricle is blocked. Wow, that left ventricle is really going to become affected. It's not going to pump. It's going to affect its preload, afterload, contractility. You're going to have a mess on your hands, and then stroke volume is going to fall, and so is cardiac output. So patients who have those type of heart attacks are really at risk for cardiogenic shock. Other causes of this condition are like pericardial tamponade, and this is a diastolic dysfunction where there's going to be issues with the chambers of the heart being able to fill properly because you have too much fluid surrounding the heart, so they really can't fill. Cardiac output is going to fall. In addition, dysrhythmias, as I pointed out earlier, myocarditis, endocarditis can cause this. Also structural issues like issues with the valves or the septums in the heart. Now let's talk about the signs and symptoms of cardiogenic shock. So whenever you're trying to recall these signs and symptoms for exams, think about what is going on with this patient. We know that there's decreased cardiac output. So we have decreased cardiac output. There's a limited amount of blood that's going to all those organs and tissues that depend on that heart to pump them fresh oxygenated blood. So a lot of your signs and symptoms are going to stem from that. In addition, remember at the beginning of the lecture I said that this isn't a blood volume issue. The heart has plenty of blood volume to pump, which, because it's weak and it's not being able to maintain cardiac output, that blood volume is going to start to back up in the heart, go to the lungs, and go to the right side. So that's really where you're going to see your other signs and symptoms. So let's look at it by systems, our heart. Our heart's weak, it's not pumping correctly. Either we have a filling issue like diastolic dysfunction, or we have a systolic issue where the blood can't be pumped forward. Having issues with contractions or some type of thing. But whatever the cause, eventually what's going to happen is you're going to have backflow of blood. Because remember, our blood volume is fine. It's going to go to the lungs. So it goes from left side back into the lungs. It's going to go backwards. Instead of going from right to left, it's really going to go left to right. And you're going to have pulmonary edema. Lungs do not do well with fluid in them. So what's going to happen in gas exchange? It's going to decrease. So you're going to get low O2 levels in the blood. Patient's going to have difficulty breathing. They're going to have an increased respiratory rate. They're going to have an increased heart rate. And chest x-ray, if they get one of those, it'll show pulmonary edema in there with infiltrates on the chest x-ray. And if they have hemodynamic monitoring, we're going to talk more about this in our nursing interventions, but I wanted to include this in the signs and symptoms. They can have an elevated pulmonary capillary wedge pressure, also called a pulmonary artery wedge pressure, greater than 18 millimeters of mercury. And what this is, it's measured through a pulmonary artery catheter, goes in through the right side, up through this pulmonary artery. And the catheter on the end of it is like a balloon that can be inflated and deflated. And it's temporarily inflated in that pulmonary arterial branch, and it can measure the pressure. And if you have a lot of blood that's backflowing into the lungs, you're increasing the filling pressure of really that left atrium, and it can measure that pressure, and it'll be greater than 18 millimeters of mercury. So keep that number in mind. In addition, you have the backflow from the lungs. It'll eventually go to the right side, because here's a pulmonary artery or right side of the heart, and then venous circulation, it all become congested, increasing pressures on that right side. So you can have JVD, which is jugular venous distention, where those neck veins will be distended. And you can have a high central venous pressure, where again, you can measure the pressure in that right atrium, and it'll be elevated from where you have that backflow of blood, and it's increasing the pressure. Now, with cardiac output wise, you can have weak peripheral pulses. You feel those, the heart just can't pump it. So whenever you feel those pulses, they'll be weak. Systolic blood pressure will be less than 90 millimeters of mercury. Patient can say they're experiencing chest pain, and this is where those coronary arteries aren't receiving blood, as much blood flow, perfusion as they should, so it can't perfuse that heart muscle. Those cells are becoming stressed, causing the patient pain. And again, cardiac index, which was that specific cardiac output based on the patient's body size, will be less than 2.2 liters per minute per meter squared. Now, another system that's going to be affected is the brain. And whenever cardiac output decreases, so does the perfusion to the brain. So you're going to have a drop in cerebral perfusion pressure. So the cells aren't going to be perfused. You're going to start seeing mental status changes in the patient. They can start becoming confused, agitated. In addition, this confusion and agitation can stem from the buildup of toxins, because the liver isn't really going to be working efficiently by filtering out toxic substances along with the renal system, and you'll be having acidotic conditions from the buildup of lactic acid. So the kidneys can be affected as well. So you can have decreased perfusion to the kidneys, of course, when cardiac output falls. And the kidneys try to, in a sense, save themselves by activating the renin-angiotensin system. And what this does, in a nutshell, is the end result is the release of angiotensin II. And that is a major vasoconstrictor. And whenever the body senses angiotensin II, aldosterone is released along with ADH, antidiuretic hormone, and what aldosterone is going to do is it's going to cause the body to keep sodium and water, and ADH is going to cause the body to keep water, because in the end what it wants to do is increase blood volume, because if it can increase blood volume, it can increase venous return to the heart, because it can get more perfusion if it does that. So whenever that's happening, what you're going to see is a lower urinary output, algluria, where you're going to have a urinary output of less than 30 cc's per hour. So as a nurse, be watching that urinary output, and if it's falling, you know your kidneys are not being perfused very well. Which, in addition, whenever your kidneys are really struggling, not being perfused, you get an increase of BUN and creatinine. So be looking at that, because that tells us our renal function. And you can start seeing signs and symptoms in the skin where tissue perfusion is just falling. The skin, where it should be nice and warm, won't be like that. It'll be cold, cool, clammy, pale. And when you check capillary refill, it will be delayed. It can be greater than 2 seconds. Now let's talk about nursing interventions for cardiogenic shock. What are we going to be doing as the nurse? Okay, first we need to know the treatment goals. What's the medical treatment goals for this patient? Well, number one, reperfusion. If this cardiogenic shock is happening due to, let's say, a coronary artery being blocked that feeds this heart muscle, which is causing this heart muscle to become weak, decreases its cardiac output, they can hopefully reestablish perfusion by doing heart catheterization, putting in a stent, so blood flow can start going back to that heart muscle. Another thing is increasing cardiac output. And we can do that by giving certain medications, and that can increase the stroke volume by altering that preload, afterload contractility. And ventilation. A lot of these patients who have severe cardiogenic shock are going to go into pulmonary edema, where all that fluid is backing up into the lungs, and they will need mechanical ventilation with this, and some diuretics to help remove that extra blood volume from the lungs so the patient can breathe easier. So as a nurse, a lot of times these patients are going to be in the ICU because they're very sick. So you'll be maintaining the hemodynamic monitoring, the mechanical ventilation due to the respiratory failure. This hemodynamic monitoring can tell us a lot about our patient and how they're responding to the IV drips that they're on and how their cardiac output is, with a central line placement to help measure those numbers for cardiac output. And they can do that through a pulmonary artery catheter like a Swan-Ganz. In addition, you want to monitor for signs and symptoms of adequate tissue perfusion. And you can look at certain body systems and tell, hey, are they being perfused enough based on our cardiac output? So look at the blood pressure. We want the systolic greater than 90. Skin color, how does it look? Is it pale, cool, clammy? Probably not being perfused very well. How's the capillary refill? Is it delayed? Urinary output, is it greater than 30 cc's an hour? If not, kidney function's probably not good. Look at the BUN and creatinine. That can show if the patient's entering renal failure. Mental status. The mental status will start to deteriorate as perfusion to those brain cells is decreased. So is your patient becoming more confused, agitated, restless? Lung sounds, that really ties to respiratory failure. Are your lungs clear? If you hear crackles, you probably have some pulmonary edema in there. And how is the rhythm? Furthermore, you'll want to look at lab results and other diagnostic testing that will be ordered to help look at the heart's function and what's possibly causing this cardiogenic shock. Cardiac markers will be ordered and they will be elevated. For example, troponin level will be elevated and a BNP could be elevated. Now, what is a troponin? Well, troponin is a substance released when there is injury to the heart muscle cells. And we know in cardiogenic shock that these cells are getting stressed out, so this can increase troponin levels, and especially can increase troponin levels if there's been significant damage to the heart muscle cells through like a myocardial infarction. Now, what's a BNP? Well, this is a substance released by the ventricle's heart cells due to stretching from high blood volume in the ventricle. And we know as that heart muscle is getting weaker and weaker, blood volume starts to back up, and that will increase the amount that those ventricles are having to pump. Other tests that can be ordered, of course, is like a chest x-ray, where this would show fluid in the lungs, pulmonary edema. In addition, a serum lactate can be ordered, and this will be greater than 4 millimoles per liter. And why are we having elevated lactic acid levels? Well, remember when we talked about the stages of shock, we talked about how the cells will switch from aerobic to anaerobic metabolism. So they are using metabolism at first with oxygen, the aerobic, but oxygen isn't in supply, so they're going to have to switch to anaerobic metabolism without oxygen, and this leads to the accumulation of lactic acid as a result. So then we'll start getting acidotic conditions where there will be a drop in the blood's pH less than 7.35. Now let's talk about some hemodynamic monitoring numbers that you need to know when we're talking about cardiogenic shock. Okay, the first one I've already hit on a little bit. It's called the pulmonary capillary wedge pressure or the pulmonary artery wedge pressure. And in cardiogenic shock, this number is going to be high. And normal is 4 to 12 millimeters of mercury, but in cardiogenic shock, it's going to be elevated, greater than 18. And again, that was with like a Swan-Ganz catheter, pulmonary artery catheter. It's inserted in that right side, and it's going to go up into that pulmonary artery, and it's going to be hence wedge, the tip of that catheter, and a balloon is temporarily going to be inflated in that pulmonary arterial branch. And it's going to measure the pressure, and it's going to really tell us the pressure on that left side, that left atrium. So if the pressure is high from where we're having the backflow of blood, it's going to be elevated. Another thing we can look at is the central venous pressure, the CVP. It will be elevated as well. And this is because we have backflow of blood causing venous congestion in this right side. And it's measured over here in this area. Now, let's talk about medications. Okay, with medications for cardiogenic shock, you can have various medications depending on what is causing it, how the patient is even responding to treatment. You may use this medication on this patient while you wouldn't use it on this patient because the response is different. These medications are going to be titrated, they're IV, and things like that. So keep that in mind. So some medications that can be used are diuretics. Why would we need diuretics? Well, remember with cardiogenic shock, we don't have a blood volume issue. This is one of the two shock types. The other is neurogenic, where we don't have decreased blood volume. Our blood volume is actually causing us some problems because our heart is not able to really pump it forward, so we're getting congestion. So diuretics can be used like furosemide, which is the brand name Lasix. You give that IV, that'll help draw some fluid out. It's loop diuretics, they'll urinate that fluid and help remove all that pulmonary congestion in the lungs. However, when you give these diuretics, especially Lasix, it can cause hypokalemia. It wastes potassium. So before you give any type of diuretics, you always want to look at electrolyte levels. And if they're getting this medication, you want to make sure your potassium's within 3.5 to 5 milliequivalents per liter. Anything lower than that 3.5, you just want to give the physician a call so they can provide some supplementation before you throw on this diuretic. So what's this going to do is it's going to remove that extra blood volume. It's going to decrease that workload of the heart. And you'd want to watch out for hypotension, because if we're taking off blood volume through having them urinated out, we can make them have a lower blood pressure. And chances are we're already dealing with someone who is hypotensive. So you'd want to monitor that closely, and if they get too hypotensive, they can throw on another medication to help increase that pressure. So be watching out for that. Also looking at their fluid status. What's the urinary output? How's their kidney function? Because we don't want to cause them to go into renal failure by throwing these diuretics on. Another category of drugs used are called vasopressors. And what these do is they cause constriction of the vessel. So major vasoconstriction. And as we talked about before, you're going to have increased preload with that because it's really just going to clamp down on those vessels, increase venous return, and preload was the amount those ventricles stretched at the end of diastole. And if you increase that in the end, that's going to increase stroke volume. So you'll have increased cardiac output, increased blood pressure. A drug that's a vasopressor used is called norepinephrine, and we'll get the results of increased cardiac output with this to tissue perfusion. Our cells will be happy because they will get more oxygen. Now, there are some vasopressors that have positive inotropic effects, and inotropic, whenever they have positive inotropic effects, that means that they're increasing the contractility of the heart, and that was another factor in stroke volume. So we're going to increase the strength of the heart's contractions, which is great because we're going to have better stroke volume, higher cardiac output. Two drugs that can do that are used in cardiogenic shock. We have dobutamine. So dobutamine increases contractility, increases stroke volume, but a side effect, because the way that dobutamine acts on certain receptors, it can actually cause vasodilation, which can, in our patient who already is hypotensive, it can cause it to get worse, and they'll probably have to be switched or started on norepinephrine or dopamine instead. So you want to watch out with dobutamine worsening hypotension. That's a big thing with that. Now, dopamine is a positive inotropic effect as well. It increases contractility, which is going to increase our stroke volume. However, a side effect of dopamine is that it can cause tachycardia, can really increase that heart rate. So you have to watch the heart rate with this medication. In addition, we have vasodilators. That's another category. And what these do is they decrease afterload, which was one of those factors in stroke volume. So whenever we decrease the afterload, it's going to make it easier for the ventricle to pump against that resistance. So we have decreased resistance that heart has to pump against, and it also dilates our coronary arteries, which is going to increase perfusion to the heart muscle. So our heart's going to get more blood flow because of those dilated coronary arteries. But a side effect of this is hypotension, so we really have to watch out for that blood pressure, make sure it's stabilized because it can further make it worse. And some vasodilators are like nitroglycerin or sodium nitroprusside. And some other things that can be ordered in a patient with cardiogenic shock are like IV fluids like normal saline. However, they're typically not ordered if you have a patient in fluid overload with like pulmonary edema, because if we throw more fluid in here in the heart, they already have fluid in the lungs from where that heart's weak and not pumping correctly. We're going to cause them some more issues. So if they are ordered, they're used with extreme caution. And fluid challenges are more common in the other types of shock that we'll be going over rather than cardiogenic shock. Because remember, blood volume is not really an issue with us, it's our heart. Now let's quickly talk about intra-aortic balloon pumps. What are these? They are a device used to help improve coronary artery blood flow and to increase cardiac output. So this catheter is inserted through a vessel. It goes up through this aorta, sets in a section of the aorta, and the catheter has a balloon at the end of it. And what this balloon will do is it will inflate and deflate at certain times, and this will actually increase blood flow to the heart muscle via those coronary arteries and increase cardiac output. So during systole, that balloon will actually deflate. So here you have this balloon, it's deflating, and whenever the heart is in systole contraction, whenever you have that balloon that deflates, it creates this suction-like pressure. So what that's going to do is it's going to suck more blood out of this weak side of the heart that's having trouble pushing blood forward. It's going to suck it out, help it go out through the body, increasing cardiac output, and pushing more blood into those coronary arteries, because coming off the aorta are the coronary arteries. In addition, whenever you have diastole, where the heart's like resting and filling, the balloon is going to inflate. So when you have diastole, this balloon inflates, the aortic valve is closed during that time. It's going to push blood flow into those coronary arteries and even further increase perfusion to the heart muscle. Okay, so that wraps up this review over cardiogenic shock. Thank you so much for watching. Don't forget to take the free quiz and to subscribe to our channel for more videos.